This time on Poll Hub, we're taking the entire episode to talk about something that affects nearly every American, either directly or indirectly: cancer. There have been incredible advances in treatments, and screening is catching cases much earlier. But there is also the troubling trend of cancer diagnoses coming at earlier ages. And then there's the cost and financial impact on families. Hematologist and oncologist Dr. Thomas Blum is our guest, and we have a great discussion ahead to look at cancer in 2026. And hi, everybody. Welcome to Poll Hub. I'm JD Dapper.
I'm Barbara Carvalho.
And I'm Lee Marengoff.
Dr. Blum, thanks for being here.
Jay, thank you for having me. I appreciate you inviting me on the podcast.
Let me put out a couple of numbers here, and then let's talk about this. According to the American Cancer Society's 2025 estimates, about 1 in 2 men and 1 in 3 women in the United States will develop cancer during their lifetimes. Cancer is also still the second leading cause of death nationally. That's after heart disease. From your perspective, where are we? Because we've heard a lot about the war on cancer over many generations or many decades. And we've had lots of progress, but these are still staggering numbers. These are a lot of people. Where are we with cancer in America at this point?
So Jay, as you had mentioned, 2.1 million new cancer cases per year is the highest that it has ever been. And there's a number of reasons for it. One is simply that the population is aging. Age is a risk factor for almost every cancer that we see, with only a few exceptions. Baby boomers are now entering the age where they are facing many health problems, as many people do as they get into their 70s and 80s. But there's also a very ominous component to that statistic, and that is that younger people are being diagnosed at a higher rate, with a higher rate of cancer than ever before. There's a tremendous increase in younger women being diagnosed with breast cancer. Millennials are more likely to get colon cancer in their 40s than any other generation that preceded them. And we don't know exactly why. Is it obesity? Is it alcohol use, sedentary lifestyle, trace chemicals, microplastics? We haven't entirely sorted it out, but there is a real problem with the increased incidence of cancer that we're seeing.
It's interesting because you talk about the potential causes and the research. Obviously, there's lots of research trying to get at why some of these incidences are increasing. There's also the other side of that, which is we have so many better treatments. Is this, in your view, kind of, again, back at that 40,000 foot level, are we in kind of a mixed bag here where things are getting better, yet things are getting worse simultaneously?
Yeah, and I think it speaks to the fact that we're not doing a good enough job in preventing cancer, but we are doing a better and better job with treating cancer. Now in 2025, entering in 2026, anybody diagnosed with cancer has a 70% chance of being alive at 5 years, which is much higher than it's ever been before. Where there's a treatment revolution going on with drugs like immunotherapy drugs, targeted therapies. Patients who were diagnosed with lung cancer, metastatic lung cancer, when I first started practice, average life expectancy 13.1 months. I have patients who have been on treatment for 10 years and are in remission. So there's been a tremendous improvement in the treatments that we have available, but the increased incidence speaks to a real problem that has to be solved, and that is, why are more people developing malignancies?
We talk about cancer as a single disease. Is that the right mindset? Because we have so many, specialists, and we focus on different aspects of cancer. Is it the right mindset for the public to think in terms of cancer as just one single disease as we think about, other types of diseases?
So Barb, it's a very good point. Cancer is definitely not one singular disease. In fact, within each individual type of cancer, we're now learning that it's not even one singular disease. Back in the early 1990s, medical science discovered a drug, Gleevec, which targeted one specific mutation for leukemia, chronic myeloid leukemia, the Philadelphia chromosome. And we thought that we cracked the code because we target this one mutation. Everybody with chronic leukemia, for the most part, goes into complete remission. They live 20, 30 years, and it's a miracle drug. Still is. But we've discovered with all these other malignancies that even within a disease like breast cancer, for example, there are multiple different subtypes. So treatments are targeted at individual mutations. Breast cancer has hundreds of them. and we're treating multiple diseases and trying to attack them from different angles.
Yeah. When I was growing up decades ago in the 50s and the 60s, I would overhear my grandparents and parents talking about, some relative who might have had cancer. And it almost was like there was a stigma associated with it at that point. It was like the voices would go down, not because I might be listening, but it was like, so it was almost like something you wouldn't want to talk about. And obviously that's not the case now, but how does it work from a patient standpoint? I mean, you give people probably one of the worst things they want to hear, and then you probably have other things that, like you're talking now, that sound a little more tenable. So, obviously the year of my grandparents is long gone, but, how's the patient, how do you generally interact with patients who are, you're probably got the worst thing, what they think it might be the worst thing you could tell them, and maybe it isn't.
Sure. Most people, after they leave their first visit with an oncologist nowadays, are actually relieved, because just like you said, they enter into the exam room for the first visit, worried that we're going to say you have 1 month to live, or we, have limited options, or your life is going to be miserable, while we're trying to treat you. And now with the treatments that we have available, there's a lot of hope. It's still never obviously good news to be diagnosed with any of these diseases, but the one positive that most patients can take is that our treatments are easier for people to be on. They have a much higher degree of success rate. We have many more options. If option A doesn't work, we have B, we have C. Some patients live long enough with their disease that drugs are discovered while they're being treated. So maybe 5 years down the road, they're on something that we don't even know exists now. So there's a lot of optimism in cancer, but it's still, obviously a gigantic blow when somebody gets that news.
No, I was just going to say that you mentioned like in 5 years' time, things can be advanced from a practical standpoint or as a practitioner. Do you feel frustrated by the research dollars available? Or do you ever get the feeling like if we just could go to war with this, like we do other things, we might be able to make progress quicker? Is that a feeling that someone, from your vantage point might have?
Well, from my perspective, the more money that we can throw at this problem, obviously, the better. So I'm all for it. And there's a lot of players in the world of research funding, pharmaceutical industry, government, universities. But obviously, I think drug development and the progress in the world that we live in is fortunately or unfortunately driven by sort of the capitalism that's behind it. And we have to live with it. But the more tools that we have in our arsenal, the better for everybody. The better for us physicians, obviously the better for patients. On my end, it's much more enjoyable to practice now when I have lots of things that I can offer people, that have a better quality of life while they're being treated. So it's, the more that can be developed, definitely the better.
You mentioned, or we just talked about the big improvements after you have cancer and you've been diagnosed with the treatments and the medications. I wanted to go back to the other thing that has advanced, which is screening, looking at people. So I had a rising PSA for many years and was under, monitoring. PSA tests and all that, had a biopsy when something showed up and nothing, and kept being treated. Finally, I was diagnosed with prostate cancer, and I've had treatment to take care of that. Who knows? I'm being monitored for the rest of my life. I'm just curious from that perspective, is I was in a privileged enough place with medical insurance and everything else, and with a good doctor to say, we need to start looking. We need to start taking your PSA every year, and then we're gonna monitor it. How important is that, and how much more improvement could we make there in terms of the screening and the looking at people for warning signs and things like that?
Sure. Primary prevention is always better than having to treat something. Screening and our preventative medicine has come a long way. I think we still have a long further distance to go as far as prevention, but some of the big successes in screening, one is patient education. More women are aware that mammogram is an essential part of their screening from an early age. technology has improved. Mammograms are now 3D mammograms. Computers assist radiologists in reading them. AI, I'm sure, is getting involved now in what the radiologists do. Things like colonoscopy, some of the previous barriers to screening for colon cancer, people are averse to having a colonoscopy performed. You want to do what? Where do you want to stick that? Now there's non-invasive ways to screen for colon cancer in terms of antigen stool testing. So people who are at lower risk can still get screened, and we catch a lot of colon cancers with things like Cologuard. We're now doing low-dose CT screening for people who are smokers, and we're catching lung cancer at an earlier stage. Lung cancer stage 1 has a 95% cure rate. Lung cancer stage 4, even if I can keep somebody alive for 10 years, has essentially 0% cure rate. So, early diagnosis is key. PSA that you bring up is, in my opinion, unfortunately, somewhat controversial. I believe everybody should have PSA, and there's definitely a public health component to it. Is it cost effective? Does it lead to unnecessary biopsies, unnecessary anxiety? So there are some entities that do not recommend PSA screening for most men. As an oncologist, I think everybody should be screened. Follow the PSA. If it's rising, if it goes above 4, it's better to err on this, because, you take a guy who's 70, who with modern medicine, the cardiologists are putting stents in everybody, he might live to 90, and he's got all his marbles. So why would you not screen somebody if you could potentially make a difference? And, that's primary prevention is by far better than somebody having to wind up and come and see me.
Along these lines, the National Cancer Institute reported in 2024 that more than 18.6 million cancer survivors are currently living in the United States. So, Jay, you are certainly not alone. It's actually about 5.4% of the population. So, from the clinical perspective, what implications does this have, for our healthcare system, to have this growing survivor population? I mean, this is certainly good news that people are living longer, people are living, with cancer. But, what is the survivorship impact on just long-term, medical care and, perhaps some quality of life challenges that some survivors might face?
Sure. Well, I guess let's define survivorship first. So it means different things to different people, and there's not one correct answer. I mean, there's people who are cancer survivors that are still living with the disease. They need to remain on some form of treatment for a long period of time. And they most definitely, in my opinion, are a cancer survivor being treated with cancer as a chronic disease. But then there's an increasing percentage, thankfully, of people who no longer have active cancer. They've successfully gone through treatment, surgery, radiation, whatever treatment comes after that, chemotherapy or targeted therapy drugs. And it does have an impact. Patients who are survivors of cancer are at increased risk for other medical problems. Certain medicines that we give increase the risk of cardiovascular disease, pulmonary disease. There's real significant importance to follow up and screening to try and make sure that if, God forbid, there is a reoccurrence, we're catching it early. There's a psychological impact. A lot of patients, when they're actively undergoing treatment, they're in the trenches, they're fighting, they're battling. They don't even really let it get to them too much because they're fighting the fight. But it's a difficult cross to bear after you get through that finish line, because then the anxiety sets in, the what if, my life is back to normal, or at least as close to normal as it could be. I don't want to go through that again. So there's a real psychological component to survivorship that's difficult. And patients don't see us as often. When they're on treatment, I see them once a week. When they're in their survivorship phase, they see me every 3 months, every 6 months. I want to check my PSA every week. Why do I have to wait 6 months? I want to know what's going on, because, one patient told me, you're only as good as your next PET scan. And, so, I mean, there's a lot to it. It's a very difficult part.
As a clinician, as a clinician, what do you recommend?
In terms of what, Barb?
Well, if someone comes to you, probably saying somewhat in jest, I'm only as good as my next PET scan. what do you recommend to them, and what kind of supports do you see that people should build, for themselves if they
Sure.
can?
Well, the best thing to do is to give them their clinical situation as you see it. You're now 6 months out, 12 months out, 2 years out. With each milestone, your prognosis is getting better. We have all this data, your blood work, your physical exam that shows that you're doing fantastic. You're doing so well. Make sure you're getting your annual physical and that kind of stuff, because thankfully looks like cancer is likely behind you. And you just have to be as straight with patients as possible. People are very intelligent. They're very well educated nowadays on their disease. And you just have to, let them know where they stand. Patients who say stuff to me like that, by the way, it's because we know each other so well after going through treatment that they, part of our visit, we laugh a little bit in addition to dealing with the serious stuff.
Yeah, I have a very jokey relationship with my doctor.
Yeah.
Same idea. A little gallows humor, but we're all on the same page. So
Yeah, I did want to ask you though, is there a battle with competing information that people go on the web or whatever, and they find these miracle cures? If I just hop up and down on my left foot 16 times a day, why don't I just do that? And why do I got to
Sure.
mess with all this stuff? Is there that frustration? Or is there a competition for, do that if you want to, but you got to listen to me too, kind of thing?
Yeah, that's a very good point, Lee. So it's less of a part of my everyday than you might expect.
Sure.
I mean, it certainly happens. People will come in and want to know if they can go on things that are only approved for dogs and horses. They want to know if IV vitamins are helpful, and the majority of the time, the answer is unfortunately no. But there are supportive care components that, allopathic medicine definitely does not have the answer to everything. So, if people want to do something like acupuncture, or they come in with certain supplements where I review the ingredients and they're not going to work against what we're doing or cause any other problems, I say, let's try it. I have a patient who was previously juicing a plant that she brought from the Philippines, and she's in remission from her breast cancer. I'm convinced it's the stuff I gave her. She's convinced it's the plant from the Philippines. We don't argue. It's probably a combination of the two. And, so as long as it's not a negative impact to what we're trying to accomplish, then I say, let's add it to what we're doing. Most of the time, honestly, the patients are respectful of my advice. And so if they bring up something and I say, no, that's, really not going to be helpful, it doesn't become an issue. I mean, usually if from the beginning, there's a real discrepancy in how I view their disease and how they view it, usually we're not a match from day one. The doctor-patient relationship's not there, and they'll seek care elsewhere. So, most of the time I don't face obstacles with regard to that stuff.
Good.
I did want to get to cost here before we end. Again, in my experience, because I'm very fortunate to have great health insurance and I was at a great medical facility, I have paid very little for treatment that I'm sure costs tens of thousands, if not more, dollars. Not everybody is so fortunate. What are we doing, or are we doing what we could be doing to ensure that there is equity for people in America in dealing with the costs? Because some of the data here is pretty eye-opening. The number of people who are in debt and how long they carry it. The 2024 American Cancer Society survey found 47% of cancer patients and survivors have medical debt related to their cancer care, and nearly half of those reported debts exceeding $5,000, and those carry on for years. It takes a long time to go away. Let's talk about the cost of this, because all of the good news, I think, has to be tempered with, but is it good news for everybody?
Yeah, and in medicine, we have a phrase for it. We call it financial toxicity. So oncologists describe in our clinical trials and published studies in journals the toxicity of treatment: who gets fever, who gets nausea, who gets vomiting, who's in the hospital for infection. All that's termed toxicity. We call, Jay, what you're talking about, financial toxicity. Mm-hmm. And all of these treatments that have created a boom in the success of oncology and treatment of cancer, they're all relatively new. So what does that mean? They're still on patent. They're extremely expensive. Everything I do for a patient costs tens of thousands of dollars. There's almost nothing I give that costs a few bucks. Amoxicillin for an occasional sinusitis. Otherwise, everything is off the charts expensive. And, the current healthcare system, a lot of patients have high out of pocket, their annual deductibles. An oncology patient will typically blow through their annual deductible in January. There's high co-pays, all the fancy stuff we do behind the scenes, genetic testing, sophisticated pathology testing, all that stuff is also expensive. And it's a major problem. It impacts how patients, perceive their illness. It impacts sometimes what we can do if patients have gaps in their insurance. In my opinion, the only real solution is to broaden coverage for cancer care. Almost nobody has enough money in the bank to pay. I've had one patient in my career pay out of pocket for his cancer treatment. He was a farmer. He owned something like 40,000 acres of farmland in Iowa. But nobody else can do it. Even people who otherwise you would think are very successful, cancer care is not even affordable on those levels. So we need better coverage for people. The one point that I do want to bring up is that there's a lot of underutilized things for patients. There are resources through the pharmaceutical industry. There's resources through foundations, Prostate Cancer Foundation, Multiple Myeloma Foundation. There's charities. Oftentimes at the end of the year, there are ways that patients can help defer the cost of their drugs that go underutilized. But I agree with you, it's a major problem as everything we do becomes more and more expensive.
Yeah.
So just before we let you go, looking forward, what do you think the future of oncology will be, we'll say in the next 5 to 10 years? And is there something that's kind of in the works that gives you the most optimism right now?
So the most optimism by far is drug development. I think with the explosion that we're seeing with things like AI, the Human Genome Project, our ability to discover more mutations that drive cancer growth and cancer development, I think that there's going to continue to be more and more improvements in our ability to treat cancer with medicines that have lower side effects. I think the flip side of that is to follow up on what Jay was saying. I think as cancer becomes more of a chronic disease and these medicines are developed, I think we really, as a medical society, are going to have to face the cost question. Because one of the unfortunate things is that for patients who present with metastatic disease, for any type of metastatic disease, still most of them are not cured. And what that means is that they need to be on treatment forever, just like somebody with diabetes, just like somebody with chronic heart disease. So we're going to see that number, 5% of the population as a cancer patient or cancer survivor, that number is going to go up on both ends. Hopefully the incidence goes down, but as more and more people are not dying from cancer, part of that is going to be more and more people are living with cancer as a chronic disease.
So before we let you go this time for real, you're doing a podcast. Tell us about that. Why and what's it about and who's the audience and promote.
Thanks, Jay. Yeah, so Medical Insights with Dr. Thomas Blum. It's a patient-centered podcast. I invite other physicians on as guests, and we basically talk through the kind of questions that patients have with their first or second visit with an oncologist. And it's kind of a behind-the-scenes look on how myself and the other docs will answer these questions, how we'll think about their medical diagnosis, how we'll think about treatments, and it gives patients a chance to see what goes on with their care behind the scenes. Thank you for asking about that.
Yeah.
Absolutely. We will put a link in the show notes. So for folks who are listening to this and you want to subscribe to next podcast, it's a good one to subscribe to. And Dr. Blum, thank you so much for being here and sharing. I think the tricky part for someone in your profession is that you've got so many layers to this. So there's the finance we were talking about, which is kind of out of your hands. There's the screening, there's the treatments, there's the difficult conversations you have with patients. You're a hero to me. Anybody in your line is a hero to me. I have personal experience with that, but I just think what you do is really difficult, and I'm glad there are people like you in the world to make it happen.
Thank you, Jay, and thank you, Lee and Barb. I appreciate all of you guys inviting me on Poll Hub. Have a good day.
That'll do it for Poll Hub this week.
Poll Hub is produced by the Marist Poll at Marist University in Poughkeepsie, New York.
Mary Griffith is our executive producer.
Casey Schaff is our production supervisor.
The Poll Hub team includes AJ Gambino, Tommy Rogers,
Cassie Connors, Sylvia Weiser, and Molly Goodger.
If you enjoy Poll Hub, consider telling a friend about us.
If you'd like to learn more about polling and survey science, check out the Marist Poll Academy, our free online learning portal accessible from our website.
Remember, you can always tell your smart speaker to play Poll Hub, and with any luck, it'll cooperate.
Finally, wherever you listen to Poll Hub, there is a subscribe button. Click it, and the latest episode will be ready for you in your podcasting app as soon as it's released.
We'll see you next time.